so easy for me to kind of
And it was funny because there was a lot of pastors in my class, right? And one of them was from Chicago, and I talked to him about naprapathic medicine. He was like, I know about that.
That's funny.
Really?
Yeah.
And then it was so funny because we're talking with him, then the lady from Kansas, and then there's two ladies from Atlanta, and then one from Louisville, Kentucky, you know, and they were all like interested. Right?
And it's so easy to get people on board with the problem.
And it was pretty interesting because two of them.
What's the most logical system?
Yeah, two of them
really?
were breast cancer survivors, but one of them knows that it was caused by the DDT that she was exposed to as a child. The other one, they're really not sure. You know, she didn't have like a high. Her family didn't have a high incidence of cancer. And then what happened was, as a result of the radiation and all the medication she was given, she got like a brain injury. And so poor thing, she's really trying to figure it out for herself because she's on disability right now, and her brain function isn't all there, you know. So this is like the third time she's gone to that class to kind of read. DDT is it's basically a pesticide, and her mom saw one insect in the house. And at that time, they wanted to get rid of insects forever, so they had DDT.
All right. Let's jump into this real quick. We only have a few minutes here, so
sorry.
Let's finish this up. That way we have this one done. So Gino Valgus and Genuverum. So Gino valgum is a medial positioning of the knee relative to the ankle or knee or knock knee. So its associated movement is going to be ankle pronation. So you're almost always going to see Gino valgum with pronation. Does that make sense? So you're going to have that external rotation of the foot, dropped arch. That's almost always going to go together with an anterior movement of the femurs themselves. Genuverum is a lateral positioning of the knee relative to the hip and ankle or bow-leggedness. Associated movement is going to be supination. So if your knee is across the midline of a gravitational line like that, in order to stabilize yourself, you're going to have to put the weight of your body onto the inside part of your foot. So you will. It can happen, but it's incredibly rare to see somebody with like a Verum presentation and also a pronation. Now, a lot of people will have like a foot that's more pronated on one side and then supinated on another side. Like you'll see this a lot with the right leg will be pronated and the left will be somewhat supinated. Whether it's the right leg dominance, previous injuries, driving a car, I'm not really sure why. The most frequent is going to be bilateral valgum or verum. Okay. So some of that has to do with genetics, the actual shape of the arch. There's a longitudinal arch, a transverse arch, but you can alter them based on changing your foot position. So whether it's an orthotic, that can actually by correcting a pronation, you can actually change the valgum position as well. So you can imagine if somebody's in a valgum position, they're much more likely to hurt what structures in the knee.
Which one?
Valgum.
MCL.
MCL. Medial meniscus, also the ACL. In a verum, you're more likely to hurt the LCL or fibular collateral ligament. And there's some interesting correlations to athletic performance as well. One thing that I've noticed over the years is people that are flat arched or pronators tend to have a faster top end speed. So I believe it's because they open up their hips better and they can cover more distance with a stride length. And I've found that people that are supinators change directions better in short motions. So in football, for example, you may notice that more wide receivers are 6'2", 6'3", are more pronated, are longer striders but don't change directions as well. And you'll see a lot of cornerbacks who cover them who are 5'10", 5'11", and they're more Genuverum and toe in. So they're very good at accelerating and changing directions, but their top end speed isn't quite as good. So there are some benefits and costs to some of these as well. In a Gino valgum position, you're going to have more ability to engage your glute max because you're slightly externally rotated already. At least at the extension phase of your drive, right? The verum is actually going to preload you at the drive phase. Your glute max is going to engage more at the drive phase. You're also going to have a more linear pattern of engaging your calf to your quad to your hip. So somebody with Genuverum is going to accelerate off the line faster just on a basic physics premise because the lines are shorter. But also, as a result of that, their hip extension isn't going to be as good. Like, because they can open up their hips more in a valgum position, they're going to cover more distance at the extension of that stride. Or somebody in a verum position is going to have to force the motion through the anterior component because they don't turn their femurs out. So those associated positions go hand in hand, too. You're going to have some internal rotation of the femur when you have your valgum presentation. Oftentimes, a more medial position of the patella as well. Whereas when you got Gino valgum, you have pronation. Patella is going to be more lateral. Femurs are slightly externally rotated. Pelvis is forward.
So maybe what I could do to correct that.
Some of it's bony, so some of it can't be corrected. You can work corrective exercises to go the opposite direction. And you don't have to be, if you're pronated or supinated, you don't actually have to have movement off the midline, right? Like you could have just like a little bit of valgum. It doesn't have to be dramatic. So if it truly is lateral and medial in that position, there's not a ton you can do, right? The musculature itself, you can work the opposite muscles to try to correct it upstream and downstream, but sometimes that's just the position that your knees are in. So neither of those are optimal, right? Like you'd rather have linear lines. You'd rather not have valgum or verum overall. So associated with that as well, like when you have a pronation, you're also more likely to develop peroneal tendonitis. You're also more likely to develop plantar fasciitis, tarsal tunnel syndrome. If you're a verum person that also has supination, you're more likely to sprain your ankle. You're more likely to have ATFL damage, posterior calcaneofibular damage, fibular head disruptions, LCL tears. So there's associated mechanical problems with both components of that. So linear is generally better, right? Like we're looking for symmetry mostly. So pes anserine tendonitis or bursitis. The pes anserine is a confluence of tendons of the semitendinosus, the gracilis, and the sartorius. The pes anserine bursa lies underneath this confluence and can be subject to mechanical pressure of one or more of the muscles that attach that are shortened. Also, because of the superior attachment from the medial collateral ligament, the bursa can become inflamed after an MCL injury, even if it's a grade 1. The tendons can cause pain in the sheath similar to other tendonitis or tendinopathies due to overactivity here as well. So you can see here that bursa lies right there in the medial portion right there, and pes anserine means what from the Latin? Goosefoot. Okay, yep. So we see how the MCL ties in here. Here's the common tendon attachment for the semitendinosus, sartorius, and gracilis. It's not actually one tendon, right? They attach at the same point right next to each other, but it's not one tendon. Similar to the iliacus and the psoas major, they have distinct tendons. They may move together in a sheath. They may have fascial components that connect them and bind them together, but they do have distinct tendons as well. They attach right next to each other, just like your pec, your lat, and your teres attach right next to each other on your humerus. So, like, for example, if you detach your pec major, you may notice that you have problems with latissimus dorsi or teres major as well because they attach right next to it. Also, right, our coupled mechanics are going to be off as well because we don't have the same amount of force from the latissimus as we do on the pec. The same can be said here. The terrible triad. The terrible triad is a traumatic knee injury, usually caused by medial torque and anterior shear of the knee, the damaged structures of the MCL and ACL via anterior and medial torque, the medial meniscus from the shear, as well as the impaction of the medial femur on the medial tibia. So you're likely to damage all three of those, also known as a Donahue's terrible triad. So you can see right here, here's our torn ACL, here's our torn medial meniscus from the impact. Sometimes it could be the shearing force as well, and then we have our torn MCL. So the most common group that we're going to see this in are going to be teenage female soccer players, at least from a non-contact perspective. From a contact perspective, you know, basically anything where somebody could step on your foot or tackle you or some issues like that. Baker cysts. In adults, Baker cysts usually arise from almost any form of knee arthritis, e.g. rheumatoid arthritis or cartilage damage, particularly in a meniscus tear. Baker cysts can also be associated with Lyme's disease. So the synovial sac of the knee joint can, under certain circumstances, produce a posterior bulge into the popliteal space. Most Baker cysts maintain this direct communication with the synovial cavity of the knee, similar to ganglion cysts. So you literally have synovial fluid or hyaluronic acid leaking out, and it's being held there in a cyst-type position. Sometimes the new cyst pinches off, and Baker cyst can rupture and produce acute pain behind the knee and in the calf and swelling of the calf muscles, which can look like compartment syndrome but not be compartment syndrome. So we can see a nice little picture here of how synovial fluid leaks out the back. These are palpable. You don't ever want to push on them or touch them. It's not soft tissue. It doesn't respond to manual pressure. You will just make it more inflamed. Usually they'll respond well to corticosteroid injections. Sometimes people will have them drained as well. But generally speaking, corticosteroids work pretty well in those areas. So oftentimes they could flare up as a result of excess inflammation or arthritis or some form of joint damage themselves. So having a medial meniscus tear, for example, like a radial or transverse in particular, you may be more likely to develop a Baker cyst as a result of that because the meniscus helps to create part of the joint capsule itself. it gives it a space to leak out of. All right, Baker's cysts usually require no treatment unless they are symptomatic. It's very rare that these symptoms are actually coming from the cyst. So keep in mind, guys, like the bones really shouldn't touch that much. Like you can almost think of it hydraulically, like the fluid in there under pressure should actually keep some space from the joints. They do articulate, but it should diffuse some of the pressure there. When you don't have synovial fluid or you've lost some of that fluid in there, now we don't have that same hydraulic ability to resist pressure. So there's more articular impaction and compaction on the joints. So now your cartilage is having to work even harder because it doesn't have that boost of a fluid around there to help keep some space, right? Because if you compress it, basically it'll resist with equal amount of force, right? Force in equals force out. If I push a certain amount of newtons on the table table pushes back on me, correct? All right, Baker's cysts usually require no treatment unless they're symptomatic. It is very rare the cases are actually coming from the symptoms are coming from the cyst. So the cyst can rub against, pick your nerve. It could be rubbing against the popliteal muscle, the ligament. But oftentimes it's not truly the case. Often rest and leg elevation are all that's needed. If necessary, the cyst can be aspirated to reduce its size, then injected with a corticosteroid to reduce inflammation. Surgical incision is reserved for cysts that cause a great amount of discomfort to the patient. A ruptured cyst is treated with rest, leg elevation, and injection of a corticosteroid into the knee. Recently, prolotherapy has shown encouraging results as an effective way to treat Baker's cysts and other types of musculoskeletal conditions. So the thought process there would probably be to create an inflammatory response to cause fibrosis to try to shrink that area up or cut it off. So you're basically creating a scarring effect to try to block off the area of which that synovial fluid is leaking out into the Baker's cyst. Obviously not really researched that much, but there have been plenty of cases anecdotally that have done well. Patella femoral joint, the tendons are designed to withstand large tension forces, but not compression or friction forces. That's how tendons work. So medial retinacular provides medial resistance, and when torn, the patella dislocates medially. The same thing can be said about the lateral. Lateral tracking is medically treated by cutting the IT band and lateral fibers to allow the patella to glide into the patella femoral groove without lateral deviation of the patella. This very rarely is effective.
Yeah.
Anytime you're cutting something, remember, we're talking about our length-tension relationships. There should be pull from both sides. When you sever the tissue on one side, now we have a major deficit over here. So think about like two wires pulling on a tent pole. And one side is damaged and it's pulling it down that way, but the other side is able to give resistive forces to keep it straight. Once you cut one, the other one's going to yank it completely out of position. You're going to get abnormal mechanics. You're going to have grinding and arthritis and probably lead to joint replacement. So there's very rarely a case where you either want to, take a tendon and reattach it to a new spot because it changes the arthrokinematics of the joint. It doesn't function normally anymore. If I change my pec attachment or my extensor bundle attachment, it doesn't function the same anymore. Right? The force distribution is forever changed. It's also unpredictable to us as a clinician. Cutting tissue as well, whether it be the medial retinaculum, a lateral release, they're not a good idea. You don't want to cut tendons. It will forever change the arthrokinematics of a joint. Like you got to be super desperate to do some sort of procedure like that. They are going out of style. They were much more popular 10, 15 years ago, just like other surgeries that have kind of come and gone. Like microfracture surgery, for example, like in the mid-2000s, everybody was doing it, right? They had punched these little holes into the cartilage, hoping that the blood would cause the cartilage to heal, but really what it did was weaken them in the end, and we had a whole bunch of NBA players that had their careers cut short as a result of it. Greg Ogden, Grant Hill, several NBA players, went through that procedure and did really poorly. Now, maybe they would do better if they weren't in an impact-related sport. I'm not really sure. But generally speaking, you don't see a lot of surgeons doing that procedure anymore. Q angle, decrease of change from the tibial tuberosity to the ASIS, aka the front of the pelvis, in relation to a direct vertical line from the tibial tuberosity directly superior. Normal Q angle is about 170 degrees in relation to the 180 degree norm. So the femur should move medially on everybody. It does relatively move more medially on females than males. 13.5 to plus or minus 4.5 degrees is considered normal Q angle for a healthy subject between 18 and 35 years old. A Q angle for a woman is 4.6 degrees higher than that for men, and that's an average, right? So there's going to be variations of those. So the high-level Olympic female sprinters you're going to see with more narrow pelvises. The reason why is that gives them a linear, direct way to distribute force in a linear fashion. The wider your hips, the less linear the force distribution. Does that make sense? So your forces can be down and slightly out instead of linear and straight line. Okay. Women have a slightly greater Q angle than do men because of the presence of a wider pelvis for childbirth, increased femoral anteversion, and relative knee valgus as well. So you can see here this angle. When we increase the Q angle, what you're going to see is anteversion of the femur itself, meaning it's more forward relatively, particularly at the trochanter. What are the consequences of that? Well, you could have overstretched quadratus femoris, overstretched glute max, glute med. They're basically in an elongated position already, meaning that they're more likely to be weak. Also, that femoral position there can cause compression of the anterior components of the hip flexors as well, leading to bursitis potentially. Also, can cause friction on the IT band. Potentially, yeah. Or posterior, depends on what you're thinking about, right? Like, and this is where you got to be careful with biomechanics. Like, if you start thinking about things like this, like that doesn't exist, right? The skeleton can't stand up without muscles. So when you start thinking about if this does this, this does this, this does this, that it doesn't create a true picture of what's really going on. Because we have synergistic muscle activation, we have a couple of biomechanics, all these other things. So you would think on a skeleton, if I had a posterior tilt of the pelvis, what would happen? Well, the femur would move forward relatively, yada, yada, yada. But that doesn't actually exist in the real world because our body's really good at compensating. So I would encourage you not to get into that frame of reference, and that's why I was teaching more of a arthroproblematic pelvic theory as opposed to everything moving in unison. Like when you get into that, you'll get so confused you won't even know where to start. Like, well, I've got nutation of the sacrum, which causes bilateral external flare, which causes the femurs to change in the knee, and you're just going to be like, where do I even start treating? So I would encourage you to always start with muscle fascia and then work your way back to bones from there. Rule out muscle fascia first. Treat those. If it looks like the femur is externally rotated, treat the glute max, see what happens. If it doesn't correct it, then you can come back to the bony position, and maybe you need to make a change there as well. Okay? Two joint muscles. So knee flexion combined with hip extension. Hamstrings lose force generative ability to flex the knee when the hip is in an extended position. So all muscles across two joints have the ability to either exaggerate their force production or decrease it depending on the other joint that the muscle is associated with. So if the hip is in extended position, the hip is extended, I have now shortened the ability for that muscle to create max force, so I lose the ability to flex the knee. Not completely, but I can't generate the same amount of force. So to get max flexion of the knee, I would actually want my knee in the completely flexed position. This is why seated hamstring curls are going to get better hamstring activation than lying hamstring curls. Because my hip is flexed. Therefore, I have the ability to generate a longer range of motion when flexing my knee. If my hip is extended all the way, I don't have the same ability to generate force through the full range of motion. Therefore, I don't have the ability to flex the knee as much. I'm also going to put more strain on it, risking tearing or other types of things. So I hate lying hamstring curls. It's a terrible exercise. You're risking tearing it, and you don't really have a lot of force production there. A seated one is much better for you in that position. If you're trying to work your gastrocnemius, right, you need your knee extended completely. If you're trying to do calf raises, if you're doing a seated one, because the knee is bent, now I'm going to engage my soleus because I don't have max tension on my gastrocnemius. So knee extension combined with hip flexion. Here's another one. Due to hamstring tightness in the strain, there's difficulty extending the knee fully when the hip is flexed. Forced flexion of the true extensor of the knee due to shortened position of the rectus femoris and hip flexors. Okay, so knee extension combined with hip flexion. Everybody follow? So this is the same thing. In order to get max quad activation, in this case, I want to be flexed all the way forward, at least with the lower component. So if I lean all the way back and I do a knee extension, I'm preloading the muscle, which one, compresses the kneecap already. That's not really what I want to do. Two, it initiates the hip flexor component to where I'm not going to be able to distribute force to my knee extension as much. So if I wanted to do knee extension, I would want to be all the way down here, take the tension out of this portion here as well, and then I can extend the knee better there. So everybody try that. Lean all the way back and then extend the knee. Try to get a good squeeze. Now lean forward and extend it. You should feel it more in the belly of the quad as opposed to the knee when you're bent forward. And when you lean back, you're going to feel more around the kneecap itself.
Yeah.
Some of that has to do perpendicular with lines of force as well. So if you want the knee itself to be lower than the apex of the quadricep for force activation, if the knee itself is higher relative to the femur, that's going to be the fulcrum, and that's where the max force is going to go to, which is not what you want because it's going to compress the cartilage. So you want the knee lower than the apex of your quadricep muscle. So also we have knee flexion combined with hip flexion. So favorable length tension relationships which allow less cramping of hamstrings or optimal force generation. This is kind of the same thing we were talking about a second ago. Knee extension with hip extension. In closed chain motion, hamstrings and quadriceps co-contract to elevate the body or lower the body, as in squatting. When you squat, you're engaging both hamstrings and quadriceps together. People don't really think about that. Like if you're bench pressing too, it's your bicep and your tricep, particularly if you use a real grip. If you use a false grip, you might take your bicep out a little bit. Okay, hip flexion combined with plantar flexion. These are kinetic chains, right? That's the simplistic term for these. Are kinetic chains. During the drop phase of the squat, there's dual eccentric forces to control the motion. So you're engaging your hammy when you're squatting. Hip flexion combined with plantar flexion of the ankle. It's difficult to achieve hip flexion with and low tensile strength. So try flexing your hip, but keeping your toe plantar flexed. See how much force you can generate there. Now dorsiflex and do the same thing.
Some more with dorsiflexion.
Feel more power with dorsiflexion? It's a kinetic chain. You guys feel it? So this is important when teaching people how to run and how to create force and even how to work out. So that's kind of like we were talking about with the breaking of the grip. So knee extension with plantar flexion of ankle. Due to full elongation of gastrocs, it's an optimal position to generate force. So to generate max force in my gastroc, I actually want my knee locked out because it's going to be the longest possible position for my gastroc to generate force. If my knee's bent, I can't create the same amount of force. And I'm going to use my soleus because it doesn't cross the knee joint. Oh, we're over time, aren't we? We got a few left here. Okay, we'll call it a day.
Well, the NASM